Hi, my name is Lynn.
Hi, my name is Mary.
And we have with us here Dr. David Garenbeck Shim. And he's a full-time psychology professor at Boston University. And he's also a licensed psychologist. And I guess our first question for you, Dr. Shim, is, in your experience as a psychologist, have you ever dealt with sexually traumatized children? If so, how long?
Yes, I have, and sadly, I've actually been dealing with kids who were sexually abused since I was doing my training. This is a clinical issue that comes up pretty regularly. So, back as early as 1987, 88.
How do the ages range for these patients?
The youngest child that I treated was 4.
Do you find that these children and young adults have difficulty recovering emotionally?
The answer is actually yes and no. There's an issue of temperament of the individual and the amount of resiliency and support that they have. That seems to be critical. Two people can go through the same experience, and one becomes more traumatized than another. So, in my experience, again, it comes down to resiliency, which are certain buffering factors in terms of how, what kind of sense the kid has of him or herself, their relationships that support them, things like that. Given that, if you have a pretty resilient kid, they can certainly bounce back. There's also been situations where even kids with those kinds of supports, for whatever reason, have a much tougher time adjusting. So it really, clinically, it's almost like on a case-by-case basis.
What specific aspects of their life do they have the most difficulty recovering, and how do they differ amongst children and young adults?
I think one of the main areas that they have trouble with, especially the kids who are given the diagnosis of post-traumatic stress disorder, their relationships and their ability to function in the world. Typically, these are kids who have problems in school, peer relationships and relationships with others, because a lot of them have damage to what Janoff and Bowman call the illusion of safety, that until trauma hits you, you just think that it happens to somebody else, and if you're psychologically injured, then you realize that it can affect you, and then depending on what their level of functioning is, relationships, school, anything that's work or activity related, a lot of them just withdraw, sort of shut down. There's a general rule of thumb, which unfortunately our diagnostic system doesn't make a huge distinction. Our diagnostic system doesn't make a big distinction, whether PTSD is for a child, an adolescent, or an adult. It's just PTSD, presence or absence thereof. But there is a V code, which means it's a clinical issue. It just isn't diagnosed as such, and that would be the sexual abuse of a child. But the general clinical rule of thumb is that the younger a child is abused, the more likelihood that there's probably going to be deeper injury. And one of the issues that we know is whether it's a simple trauma, which is a poorly named term. Simple trauma means a one-shot trauma or a multiple trauma. If a child, an elementary school kid, is abused sexually, there's probably greater likelihood that it's going to injure them because where they are developmentally, and it seems to set them up for later traumas. If an adolescent is injured, certainly they will have their own issues, but the other likelihood is that they may actually have more internal resources. They can speak about what happened to them. So the most important piece is the sooner that they are able to communicate this to someone, somebody offers them help. And even, the kind of treatment that we would give would be slightly clinically different. The younger a kid, it's more about containing and helping them sort of get back on track so they can do the trauma work later. Okay? With adolescents, they need to do the process a little bit more.
So, emotional and psychological trauma can sometimes manifest itself physically in victims. What are some of the physical symptoms of sexual trauma, and how do they differ in children?
That's a great question. Typically, the common sense, perspective would be that if children or anybody is sexually abused, that they would in fact, flee from anything that sort of triggers anything sexual. And you do see some of that. People who tend to shut down, sort of go to the PTSD reaction, okay, around trauma related stimuli. The one interesting thing about sexual abuse per se is that there's more likelihood of reenactment. That means that kids become much more precocious. They're much more knowledgeable about things that often they shouldn't have information about. And they're more likely to act out sexually. That's been sort of my clinical experience. That's why they get referred to me, because they're doing these things that other kids their ages don't do at school. Okay? The little 4-year-old I was asked to evaluate was in fact sexually assaulted by a bus driver, and she was acting out with other kids in the bathroom, the after-school program, the preschool that she was in. So it really, again, is a case-by-case basis, but particularly you have kids reenacting it somehow, showing, symptoms about what had happened in their day experience. Because reality is that they can't really process it. They don't have the psychological tools to really manage, understand, incorporate, work through. And in fact, we also know that there's a body of research that shows that their relational templates, their relationships with themselves, with others, the world, and the future gets debilitated. And we would actually call that a depressive mindset. So you actually have anxiety, depression, fear of being re-traumatized, all kinds of somatic problems, and just fear.
With sexually traumatized patients you've dealt with, have you noticed any patterns with how they interact with their family?
If you're talking about sexual abuse of children, almost always the perpetrator is known to the child because they have to have access to the child. And what happens with that is then the relational templates, meaning that their ability to relate to people gets damaged. So often what will happen is that the kids become even more, they usually regress, more clingy. You see earlier, more developmentally inappropriate kinds of behaviors resurfacing. Probably one of the more common ones is anti-rhesus, wetting themselves. You actually could have a kid who's pretty much potty trained, okay? Starting to wet themselves at night, in the day, all kinds of things like that. So it's their relationship. I don't think you can make a particular prediction about how they're going to relate. But if the parents are tuned into the child, they're probably going to sense something is different about the kid.
So, what would you say about how the family treats the child?
Well, you're talking about two different things there. You're talking about culture and also family. There's some cultures, I think American culture is much more aware and open to some of these kinds of things happening in their kids. You also have some cultures where they're just in massive denial about what goes on. So I think how a family protects their kid, how they bounce back, all of these things are probably, if the family is basically very supportive and understanding, that's going to be a plus. The family is not understanding, the kid's going to shut down. On one level, the kid may be able to shut down and sort of function okay, but the difficulty is that these things don't just disappear. So the whole idea, why don't you just get over it? Why don't you just forget about them, those things? If that worked, okay, we wouldn't have PTSD. It affects the brain. That's we know that. And the younger the child, the greater the changes in the brain, like the corpus callosum, the HPA axis, which is the hypothalamus pituitary adrenal system,